Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode, and at any time during today's presentation you may submit your questions via the general chat located to the right of the slideshow. It is now my pleasure to introduce today's first presenter, Ms. Jen Braun.
Thanks, David, and thank you all for joining us today on our webinar, Teams Saving Brains 1 Minute at a Time. My name is Jen Braun, and I'm a Senior Program Manager at the Health Research and Educational Trust. We are part of the American Hospital Association, and we're extremely pleased to offer this webinar today. And all of this Team Steps work is funded by the Agency for Healthcare Research and Quality, or AHRQ. So we would like to say a big thanks to them. So just a few rules of engagement and some announcements before I toss this over to our speakers today. But I just wanted to highlight that audio for the webinar can be accessed in two ways. So you can either dial in through your phone, or you can listen to the audio through your computer speakers. And you'll see that to the right of this presentation, to the right of the slides, there's different boxes. We call them pods. In the note pod, there's the dial-in information and the passcode if you wish to dial in through your phone. But just know that we will do a moderated Q&A at the end with our presenters. So if you have any questions throughout this webinar, please feel free to chat them in. And some of the other pods that you'll see is the Files pod on the lower left. If you click that, you're able to actually download the slides from today's webinar. And please also know that this webinar is being recorded, so we will be posting this on AHRQ's website, and we will alert you all once the webinar has been posted in case you want to share with others. And then to the right of that are some web links, and so that goes into some of the upcoming Team Steps events that we want to share with you all. So we offer master training courses 2 days in person that are now available through September 2017. So in the web links pod, towards the bottom of your screen, you can click on any of those links and it will take you to that event information page on AHRQ's website, including the master training courses. In addition to the master training courses, we offer Team Steps advanced courses. So this is a really unique course. It's 1 day in person at these 4 sites across the U.S. this summer. And really what it is it's not a Team Steps refresher, but rather a look at how to really tie Team Steps into other initiatives, taking a better look at coaching coaches, the business case for Team Steps. So it's kind of these higher level, more advanced concepts. It's a really interesting course. So if you're interested, we are accepting applications for the courses through May 19th. So you can click on any of these hyperlinks too, and that will take you to the page on AHRQ's website. And then finally, 2 other upcoming events that we don't have listed here is a new offering we have is Team Steps for Office-Based Care Online. So if you're working in a clinic or an ambulatory or a primary care setting, or you know of others that work there and would like Team Steps training but can't necessarily go in person, we have an online course specific to the office or clinic setting. So there's information on that in the web links pod. And then finally, these webinars, we offer them on the 2nd Wednesday of each month. So our next webinar is on May 10th, a group from Kaiser's presenting on Team Steps in the perioperative setting. So that will be interesting. And then finally, we offer a helpline. So if you have any questions, comments, want to get connected to others, please either call us or email us there. And then with that, enough of me talking, I'd like to turn this webinar over to 2 speakers from Christiana Care. Christiana Care has been very involved in Team Steps. I think we were talking earlier before we started that we've had a presenter at our national conference nearly every year for the last 5 years from Christiana Care who've done a lot of great things with Team Steps. So we have Dr. Susan Coffey-Zern and Dr. Barbara Albani. So with that, I would like to turn it over to the 2 of you. Thank you.
Good afternoon, everybody. I'm Sue Coffey-Zern. I'm Barbara Albani. Nice to meet you guys. And we are going to start by just talking a little bit about us. we want to just kind of give you a global overview of us. Well, I guess we should start with the objectives. We're going to describe the process of improving stroke team response using team steps, framework, and tools. We're going to recognize the value of an iterative approach to improving team effectiveness. We're going to discuss the importance of using clinical data and feedback to improve and sustain team effectiveness. And now I guess we should just kind of give you a little background about our hospital system and who we are. You can see we're in the green. We are in Delaware. We're in the northern part of Delaware. Christiana Care Health System is located in Delaware, but has a presence in Pennsylvania, Maryland, and New Jersey as well. We have 2 hospitals. One is in Wilmington, the other is in Newark. We have a total of 1,100 beds. We have a freestanding emergency department. We're the only level 1 trauma center in Delaware. And we teach residents, fellows, medical students, nursing students, and allied health students. You can see sort of a detailed sense of our health system and the volume of visits and admissions per year, as well as how we're ranked in volume nationally. Looking at, we're 28th in the U.S. for surgeries and 31st in the U.S. for births. So it kind of gives you a sense of what we look like. So talking more specifically about, kind of what the impetus of this project was is Christiana Care is actually has a very high stroke volume. We're one of the top 10 stroke centers for admissions in the country. We're seeing nearly 2,000 strokes per year. What this webinar and what the project really focuses on is something called ELVO, or Emerging Large Vessel Occlusions. And strokes really come in a couple of flavors. You can have hemorrhagic strokes, which are far less common, and you can also have ischemic strokes. Ischemic strokes are the type of strokes where a blood clot actually lodges in a blood vessel and blocks it off, causing damage to the downstream brain tissue. And that's really the ischemic type strokes are significantly more common and really where we're focusing. And specifically within that subset, we're talking about, blood clots that affect the large vessels that feed, significant portions of the brain. Patients who have these large vessel occlusions tend to do quite poorly, and their long-term outcomes are not good unless we act. In response to the emerging technologies for treatment of these large vessel occlusions, the Joint Commission has come up with certification for hospital systems that can care for these type of complex, very sick patients. The Comprehensive Stroke Center certification came out several years ago, and there's only probably a little over 100 facilities that own this type of certification. We are the only one in the state of Delaware that has it. That means that we are comprehensive in that we have endovascular capabilities, we have neurosurgical capabilities, we have neurology capabilities 24/7. My slide advancer is a little slow. Sorry about that. So just a couple of thoughts on strokes. So, as we've known, strokes are a hyperacute emergency. Every minute that's lost in the care of a stroke patient, you literally lose millions of neurons. Years of your life will go by. And, luckily we have billions of neurons, and most of us will miss a few million. But the issue is that the quicker we get to a patient, the better that they do. And we know that for every 15 minutes of time lost, there is a significant decrease in the patient's functional outcome. And despite all this data, there seems to be, at least, when I arrived here in Delaware, there seemed to be kind of a lack of a sense of urgency. And there was clear inefficiencies in how the time was managed with these patients. We've had a level 1 trauma center here at Christiana for many, many, many years. And trauma patients, as some of you may have experienced or know, when they come into the emergency department are typically not silent. They may be, spewing blood, pardon the frankness of that, but they may be spewing blood, they may be screaming because they're in pain. But these patients are clearly in extremis. Whereas stroke patients, for the most part, when we're talking about ischemic strokes, they don't hurt. So patients come in, they may be, unable to speak, so they're quiet. They're not really complaining, and there's really not that sense of urgency. And when I arrived here, that was kind of a culture that was very, very difficult to change, but was one of the main drivers behind trying to get this project started. So, and again, the focus of the presentation is really on these large vessel occlusions. There's been a lot of work on using TPA, which is a blood clot medicine, and getting those what we call door to needle times very, very short. Again, with the idea that strokes are hyperacute. And the Joint Commission has put, get with the guidelines out and things like that, which monitor and help hospital systems achieve those guidelines and set standards for them to achieve. And what we found is that, as mechanical embolectomy, which is where we physically go in a cath lab, we thread a catheter up into the artery that's occluded, and kind of like a cork, we pull it out. We engage the clot and pull it out and sort of uncork the vessel. This has been proven in level 1 Class A evidence in multiple studies that this mechanical embolectomy is very effective in improving long-term outcomes in these patients with large vessel occlusions. So where we're at with this is we're trying to, just as we had done with the intravenous TPA, we're trying to really hone the door to what we call incision time with these patients and reduce the time to get the patients on the table for their life-saving procedure. Now, clearly, it's the operational challenges with getting patients into the cath lab are greater than just getting them IV TPA. So what we sought to do is look at the system, do sort of a decision map, and look at the process and see where we can start to affect change. And what I saw as I was looking through this was that the time from the cath lab door to the incision time, which is directly under my control, by the way, the time that the patient arrives to the door to the time I actually make incision, there was significant variability. And we really wanted to seek an answer as to why. And just like a code blue situation, these stroke codes are quite low volume, so you don't see thousands of them a year, but obviously are quite high acuity situation. And one of the things we thought is getting people exposed to doing this on a routine basis would probably be good to help them get more comfortable with how things run. So this is a slide that shows crude data. It is in fact crude, and I don't want you to look at the specific times and minutes. What I want you to really focus on is the variability. The times are really all over the place, all the way up to 75 minutes. And there was no rhyme or reason in terms of looking at patients' severity of their illness or really how sick they were, and how long it took us to actually get the patient from the cath lab door. This is not ER door. This is cath lab door to incision. So what we sought to do was to decrease that time and make it more consistent. So the goals were really to reduce the time to less than 20 minutes, and really consistently do that greater than 50% of the time. Not just to decrease it, but to decrease it as a whole over time.
And so we started with a process evaluation. We initially assessed the stroke team members in the process in the simulation center using high-fidelity simulation scenarios. And we noticed that there was a lack of clarity around roles and responsibilities. There was no formal team leader. The assumption was that the physician, like Dr. Albani, was the team leader. However, oftentimes she wasn't even in the room because she was busy talking with the family, obtaining consent, reviewing CAT scans, and planning the intervention specific to that patient. We watched members of the team would work in parallel in a very uncoordinated fashion. And there seemed to be no sense of urgency or time pressure, as Dr. Albani is talking. You know, they weren't really, you know, involved in directly assessing the patient as having decreased function. And so that was our first step, is looking at all of the different gaps. And so we started in the spring of 2004 and really tried to implement solutions to some of the gaps that we had seen in the winter of 2003. And some of the solutions that we implemented were roles and responsibilities being defined, and we used email as the way to do that. So we put out the roles and responsibilities on email that we thought were going to be the important roles for each person as a member of the team. And then they were edited and discussed by the team members. And people noticed that there were redundant responsibilities or assumed responsibilities that really weren't theirs. It was a really great exercise to ensure that everybody was on the same page, because people would weigh in and things would get deleted or added. And then using email was a really good format for busy clinicians, people who were members of clinical teams, because it didn't require us to have meetings, and it didn't require time away from clinical care. And people could weigh in. It flattened hierarchy. So you could say exactly what you wanted, and it wouldn't matter that, you know, that you were doing it by email. And then this document now serves as the source of truth as new team members are onboarded, and I think it was put out as part of their Joint Commission evaluation of the, you know, of the team when they were assessed as a stroke center. So after working through the roles and responsibility, we tested them with the team in the simulation center. The next thing that we did was team leader training. And we did training for the nurses in this new role using team steps with just really need to know information. What we were really looking for was that the expectations of the team leader, what was, you know, their ability to resource manage, delegating, and then situation monitoring throughout the time frame from the door to incision, and then cross monitoring. So we really looked to focus on those areas of team steps and really taught the nurses that. And we also realized right away that the cath lab nurse would be the team leader, and that they would need explicit training in that role. And again, since the neurointerventionalist was the doctor who was doing the intervention, they were too busy getting ready for the case. They could not play the role of the team leader. The circulating nurse, though, was a good choice because they were familiar with the room, the supplies, the equipment, the setup, and the whole process of the stroke code. So it was a much better approach to being the team leader. So then, once we did some of we implemented some of the solutions, we began in situ simulations in the cath lab on 2 Wednesday mornings per month for an hour with the entire interprofessional team. So our interprofessional team is anesthesia, the emergency medicine department, the cath lab team, the neuro ICU is part of that as well. So the frontline team had suggestions for improvement with every debrief. So we would run this simulation scenario and debrief it. And then we would see after running each session or running multiple sessions that some of the common themes needed to be changed to ensure that the process would be more efficient. And having Dr. Albani as part of our team and present for each of our debriefs allowed her to make changes and move barriers for the team. She is the director, so she could talk to the emergency department, and she could easily make the changes that would be helpful for the team. And again, she's listening to the frontline staff who's actually doing the work. So she spoke to leaders, her partners, and assisted in making the changes in the process that were identified by her staff. And they too saw her as such a huge support that they were able to continue to make, to implement the changes that they saw. The process continued to be streamlined based on us doing the simulations every twice a month and then debriefing. And so we were seeing lots of valuable changes. We instituted a formal handoff process as well, and that initially was met with resistance as the team thought it would waste time. We wanted the team to stop what they were doing and do a handoff, and we timed it, and the average handoff was noted to be about 2.5 minutes in duration, and it really saved time in the long run. We noticed that without the formal handoff, the members of the team would ask the same clarifying questions over and over, such as like, does the patient have any allergies to medicine? When was the last time he ate? And it wasted time. It had the whisper down the lane effect of providing information to the team. So if they did a formal handoff process, everybody stopped what they were doing, gathered around the patient, gave their role in the team, then the patient information was presented in what Dr. Albani calls a loud and proud format. Everybody heard what was happening. Then they discussed the plan. So anesthesia would say what they were going to do regarding intubation. Control of blood pressure was discussed for the whole team to hear. They decided if they were going to put an A-line in or do a Foley catheter. And then the team moved the patient to the table and commenced with their individual tasks. And it actually really streamlined the entire process, and people felt like everybody was on the same page. And there was a lot less chatter because people knew the tasks that they needed to do. And although there was a lot of parallel work, the CAS nurse would tell the group the time, how long they've been in the room, ask people if they needed extra support, and then could really resource manage the room based on, what the situation that was going on. So what we noticed in our in situ simulations was that they were very aligned with the outcomes that have been seen in the literature, that it did seem to improve individual team member technical abilities. People were doing their job better. It reinforced the individual and team member behaviors. It identified active and latent system issues that we were able to change as we continued to do the in situ simulations. And it catalyzed a change in the clinical care systems. We saw that people were becoming more effective and that, people valued it. And it absolutely improved our clinical outcomes.
This is some of our initial data. And, again, what I want you to focus on is the fact, obviously, that the times have been decreasing. But you see the dot, which shows, one patient over time. But what I also want you to focus on is not only that the line is sloping downwards, but you can see that the rate of scatter is coming more close to that slope, meaning that there's less variability. And that really was one of the biggest things that I took home from this, that not only are we able to decrease the time from the door, the cath lab door to incision, but we're able to do that consistently. And anecdotally, talking to people, the members of the team, they say, look, it's great. I feel much more confident walking in the room. I know what I need to do. I understand what's expected of me. We know it's an emergency, but it's, we're not like the bad news bears. We all have our role. We know what we need to do. We walk in with confidence, and that is in and of itself is fantastic. So the team really works as one more since we've started.
So we have continued the InSitu simulations. We started in 2014 and went through 2015, doing them bi-monthly. Debriefing the team after each simulation allowed us to make the iterative changes to the stroke code process. We have ad hoc teams. We have about 40 anesthesiologists. We have like over 120 nurse anesthetists, many different cath lab nurses and techs, ED nurses that come up from the emergency department to hand off the patient. And we run the sessions at 7 a.m. twice a month on a day that has protected time for the OR and for the cath lab prior to the start of the day's cases. It usually involves about 7 to 8 team members during each InSitu simulation session, and it usually lasts about 35 to 45 minutes. So they have really been able to bring down the door to incision time to much less than 20 minutes with most of our sessions. We have added a formal neuro exam, so once the patient's on the procedure table, the nurse from the emergency department stays to watch the nurse from the cath lab perform a focused neuro exam. And the emergency department nurse would be able to give feedback regarding any changes to the exam and would be able to tell the team if the patient has worsened or improved or stayed the same since the last assessment in the ED. The neuro exam is vital information that needs to be obtained in a very structured manner so that the procedure should either continue or should be or the neurointerventionalist should be made aware, and they can decide if they want to stop if the patient has worsened or has bled into their head or something else, and they can decide the next steps. But we've found that this was a really critical component too that the team could do. And then we've taught the team about closed loop communication, about, as Dr. Albani says, being loud and proud. If you have something to say, you need to speak up. You need to let the entire team know what's going on.
So after doing this,
Ladies and gentlemen, we apologize. It looks like our speaker accidentally disconnected. Give us one moment. We'll have them back online. Please hold. Ladies and gentlemen, we have our speakers back online. You may continue, please.
we were just checking to see if everybody was awake. That was all.
Sorry.
So we're on this data slide. So we were talking about, we had been doing this for a couple of years. We had noticed a definite impact in the practice, and seeing that patients or people involved in the teams are really benefiting from the practice. And we thought, well, let's see how SCORT does if we just kind of let them go and see what they do. And what we noticed is after about a single quarter after we stopped doing the simulations, the time of door to needle started, the cath lab door to incision started to rise again. And I had a number of people come up to me and say, we really need to start doing the simulations again. We've got new anesthesia staff, we have new CRNAs, we have new ER people, and we really need to readdress this. So, the idea is that it's going to be an ongoing process and is not likely to be, a sort of a one and done.
So you can see that teamwork and communication training and practice needed to be continuous to sustain the change. And we could see drift from optimal practice without doing refreshers, role modeling, and sustained training. So we resumed the InSitu simulations again during the fourth quarter of 2016. We developed a best practice video for the participants to view prior to the simulation. And you saw the picture of the handoff. That was a still shot of the participants in the best practice video. Team steps, tools, and strategies are highlighted in that video and explicitly demonstrated using the frontline providers. We ask them to do that as pre-work prior to coming to the simulation, so they know what we're looking for with regard to closed-loop communication, with regard to the handoff, the neuro exam, and so that some of these components are taught as part of pre-work, and then they're practiced in the simulation, and then they're debriefed. So we feel like we make great use of the time that we have with our teams, and it just reinforces some of the team steps, tools, and strategies that we've taught the group. So our path forward, our next steps are to broaden the scope, and we would like to safely optimize the time from now the emergency department door to incision in the cath lab to improve clinical outcomes through a more consistent and efficient and safer delivery of the embolectomy. So we're looking to even shorten the time that the patient even arrives in the emergency department. We'd also like to develop a method for stroke team performance feedback by cameras were installed in the cath lab, and we'd like to debrief the teams after actual stroke cases with real patients instead of solely using simulation. And we hope that this will allow us to help the teams continue to improve. Our simulations don't and can't have all the complications and issues that exist in normal patient care, so this is the next logical step to help the teams continue to improve. And so this is where we're going to spend some of our time. We're going to definitely continue to do our simulations, but I think, you know, really looking at our actual cases and really working with those teams to debrief them and see areas that we can help them using the team steps, tools, and strategies, and really help them focus on actual patient cases and what would you do differently the next time. So that is our presentation, and we wanted to give you our contact information, and we are open to any questions that anybody would have regarding the project that we did.
Thank you both very much. I think this is a great example of how team steps can specifically affect a process which can lead to better clinical outcomes, which is really great. As some of the questions start rolling in, going back to some of your next steps, so working on, you know, improving time from the ED to the cath lab, are you currently doing anything in that area? Are you measuring the time? What has led you to focusing on that next?
Well, it's sort of when we did the initial process map and we looked at, you know, we're trying to identify areas where there was opportunity to streamline time. The one that I had most control over was, you know, when the patient hit the cath lab door to when we actually made an incision. So I felt that the impact and the variability in that step was the greatest. And now that we've decreased the variability, we've decreased the time, and we've gotten pretty good at that. Now we want to go back and look at the whole process from start to finish. Mm-hmm. And see, you know, are there other areas that we can streamline to again decrease? I mean, minutes really do count. So are there areas that we can further improve the patient's transit from the ED door, you know, into the cath lab? So you know, and this can be challenging because, you know, the more so than just doing IV TPA, the number of people that are involved in doing a procedure like this is significant. You know, we do have the cardiac cath, and their STEMI projects have given us some clue as to how to do this. You know, and I've been working with some of our cardiac people as well to see if we can model what we do after them. But you know, even more so, and obviously I'm a brain doctor, not a cardiologist, and I think the brain is more important than the heart. But I say that jokingly. But the brain truly is less tolerant even than the heart, and the idea of time is even more sensitive in these patients. So you know, again, heart attacks tend to hurt, strokes tend not to. So you know, we we do have some more work, and we always want to make sure that we're looking at our process, improving our process, and going through that iterative evaluation of how can we be better, where do we need to be better, and how can we decrease that time.
Right, and Team Steps is all about, starting small, getting those wins, and then translating it to other areas. And we like to say that success breeds success. So kind of going on that, was the ED staff, or were they aware of your project? Did they start saying, hey, we want to start looking at Team Steps? Has there been any kind of quote-unquote teeing up for the ED for Team Steps?
I would say not yet. I mean, we haven't worked on that component of the project yet. We have included them into the component that we're doing in the CAS lab, but I think they've seen themselves as part of that team, but they haven't. We haven't looked or discussed going from the ED door to the CAS lab yet.
Sure. Kind of switching focus, a lot of folks are really interested in the best practice video that you guys put together. So can you maybe talk more about this and maybe the decision to make this video? And so I'm assuming you used your own staff, that sort of thing, correct?
Yeah, we didn't use actors. And I had to sell a kidney or two to get people to do this. But the idea was really for clarity of what the expectation is. So, what we noticed is people would come into simulation and, they have sort of their ideas of what, team steps would be, like what closed loop communication is, and they think they know, and, how it's manifest is perhaps not what we were looking for. And while we would, in the debrief, we would talk about it, and we had, specific lectures. We gave lectures about what team steps are, what closed-loop communication is, what it means to be a team lead. There was a lot of uncertainty about what exactly that meant. So the goal, one of the goals of the video was for clarity, so people could get a sense of what we would consider a perfect handoff, what we would consider, good closed-loop communication. So there was a concrete example of what that was, and what our expectations were in terms of the simulation project. The other issue too is that the video was also helpful in that we're asking the circulating nurse to be the team lead, and there was some hesitation from the circulating nurse in that he or she is not a physician, and he felt that perhaps they shouldn't be giving direction to a physician, that was a hierarchical issue, right? And we're very uncomfortable doing that. And despite conversations and whatnot, and going through the simulation, there still seemed to be some hesitation. And what we found is when we put the video out and people could see what that team lead really was, that you're really more of a cruise director and not the captain of the ship, that you're really trying to help with resource allocation and move things along, that I think it broke down some of those hierarchical barriers and helped people be a little bit more comfortable. I mean, we still have some, and I wouldn't even call it an issue, but some hesitation there. And the more we do this, the better it becomes. But the video also helps with that and helped the attending physicians, the anesthesiologist and whatnot, understand that, the nurse wasn't telling them what to do, and also help the nurse understand that they weren't, telling the anesthesiologist how to intubate a patient, sort of thing.
Right, yeah. I know a lot of organizations make their own videos, and I think that's what's nice about Team Steps is there's a framework, and then you're able to customize it to, what makes sense to your setting. And so I think that by having your people in the video, being, having it produced by yourselves, and really making it kind of that grassroots effort can be really beneficial, like you just said. And kind of on that same note with potentially issues with hierarchy and silos and that sort of thing. So I have two physicians on the phone. I have two speakers who are physicians. So did you have to sell Team Steps to others, or was Team Steps sold to you? How did you get other physicians to engage? Maybe you can speak a little to that.
Well, I can speak from a person who doesn't, I mean, I'm not a team step black belt master human being. I mean, I'm one of these people who thinks I know, right? So, you know, I went through residency, you know, I survived, so I know how to work as a team, right? And I think what I've learned in this process is that, you know, team playing well on a team is a learned skill. And you know, if you think you know, you don't. One of the ideas with this whole process is really, you know, trying to get people to play like a team. It's just like anything else. I mean, if you're on a you know, a baseball team, you know, you don't just go out and play the games. I mean, you have to practice. You have to learn what the first baseman does, the second baseman, and the shortstop. Everybody's got to learn their role and learn that if a ball comes to them, what they need to do, and how you communicate, what kind of, you know, signs that you give to one another, and how you help each other out and have each other's back. And so this is a process where, you know, like any good team, where we have to practice. We have to get on the field and practice and understand what you know, what we do and don't know, and get comfortable working with each other and get comfortable with the situation. And this is particularly in these really high acuity, low volume types of situations where things can go south fast, and it's been helpful in that regard. So I would say that Team Steps hasn't really, you know, I don't know as if we're selling it as a product, like you need to learn, quote, Team Steps. I mean, we basically look at people and say, you need to learn how to play on a team.
But, you know, and I think that I am a Team Steps master trainer, and I think that the beauty of working with Barb and working as physicians was that she was very open to all the Team Steps strategies and tools, and once she learned them, then she wanted her teams to use them. And she would ask for people to close a loop, and she does that in clinical care now. So she'll stop and say, you know, I need somebody to answer when you know, answer back when I give an order or whatever. So she is constantly teaching her staff to close the loop, to make sure that people have heard what she says and tell her they've heard it. And so she, you know, she has learned a lot from doing this, and actually has continued to push that.
We call it the Bueller effect. So if I don't hear back, like if I say, you know, give 2,000 units of heparin and I don't hear back, I say Bueller. It's an old reference that most people probably won't get at this point. But the point being is that it's become part of our lexicon. It's become part of how we behave, and you know, not just in a scenario of an acute stroke, but, you know, for all of the procedures that we do at this point.
Yeah, exactly. So, and I think you kind of touched on it. I think sometimes Team Steps can be implemented or included kind of covertly, not just like, hey, everyone, we're implementing this Team Steps initiative. Rather, you're kind of taking bits and pieces of it and kind of sliding it in. And I think that could be kind of, to your point, a useful tactic for getting people on board without them really knowing we're doing Team Steps.
It seems it's a lot less formal, and I think, you know, in my experience, I think, and I can't say this would be true for everyone, but sort of introducing it, I think as the intent of what Team Steps is about, you know, and teaching people the amazing concepts that have been formalized in the Team Steps. You know, you kind of teach the why, and then you teach the how. So you kind of tell people, you know, this is why we need to do this. This is why this is important. This is how this is going to affect patient care. And guess what? Let me tell you how we're going to do that. Here's a you know, a logically worked out you know, way to do this. It's called Team Steps, and we'll work through that. So initially, you know, I think for buy-in, you know, we always talk about, you know, the why of whatever we do. And people understand why it is that they need to learn it and why it's important to learn. And once they buy into that, then you can sort of really give them the how and the tools to do that, which is what Team Steps is about.
Exactly. Yeah, I completely agree. One question that came in, and you touched on it earlier, was that it's great that team steps can affect processes and include patient outcomes, but almost sometimes just as important is it can really make an impact on staff satisfaction. And so one of the questions was, I'll read it to you. It must be great to work as a team member in your program. As you stated that the team members become much more confident when getting into the lab. How do you measure, if any, the improved team satisfaction or well-being?
Well, initially we had started, we were going to do a pre and post survey. That was the best laid plans of mice and men, right? So we had worked out this whole, human factors individual who was there, who was kind of helping us, and we designed a satisfaction survey. It didn't take off as we had hoped. The follow-up people didn't get to. The response wasn't what we had wanted to see. I think that what we found over time is that the individuals that are more transient, that come in and out. For example, we have a huge anesthesia staff and a huge nurse anesthetist staff. So getting them, quote, comfortable with a stroke code is not going to be necessarily easy. But what we found is the people that are consistently there, the cath lab nurse, the cath lab staff, really, those that are there every time that really kind of lead the charge, those are the people that have become extremely confident in what to do, and they can help lead those who come in, even to simulation training only once in a while. And I think that's where the impact really is. Not necessarily, I think the expectation shouldn't be that, every ER nurse or every anesthetist that walks into the room is going to be 100% confident, doing what you do, because they get less exposure than our cath lab people. But if you have a core group of people that are there more consistently, that are extremely confident, they can give direction and help lead those that may come in less often. And the satisfaction for the cath lab staff is huge because they feel very confident telling people what to do, in a loving way. And it's satisfying for the people who come in, only once in a while, because they walk into a well-oiled machine, and they can kind of lock and load and figure out what they need to do because they're directed to do so.
Yeah, exactly. I think when you're on a high-functioning team and things are, although chaotic, but still going smoothly, you just feel better about working together, and that can affect your care and your outcomes and all sorts of things. So that's really great.
And also, in truth, we have not been successful in being able to quantify that. And the team satisfaction is really, as I stated when we were going through the slides, is really quite anecdotal, but I think is palpable during the procedures in particular. People are much more calm, they're much more focused. And as I said, when we stopped doing the simulations, I had more than a handful of people come up to me and say, we need to start again. So there's suggestions that it does make an impact for interaction or team satisfaction.
Exactly. So a question is, have you seen issues with TPA times with a focus on cath lab incision time?
I think they're true and unrelated. I think the system as a whole is very focused on getting the patient to treatment as fast as possible. So as we're working on the cath lab experience, the neurology team is working very, very hard, and door to CT and door to incision or door to needle, that sort of thing. So they're sort of working in parallel, and the beauty of all of this is that the work that the neurology team is doing for the patients to be from door to, say, CT, that piece also plays a role in our piece, in that if we can get the patient from the ER door to the CT scanner quickly, yes, they can get TPA quickly, but we can also identify a large vessel occlusion quickly and make a decision as to whether or not they're a candidate to go for embolectomy. So that all plays a role in decreasing our overall time from ER door to incision. But we haven't necessarily noticed an effect of what we do upstairs in the cath lab in terms of a direct impact on door to TPA. The reverse, however, I think is true in that if you look at the overall times from ED door to incision, not only has our work played a role in decreasing that time, but certainly their upfront role in sort of the diagnosis and triage of those patients coming in with stroke-like symptoms has made a big impact.
Excellent. There was kind of a clarifying question earlier. Tracy Rutland wanted to know, so these procedures are done in the cardiac cath lab and not the interventional radiology suite?
Well, we put the cardiac cath lab in because most people understand and know what that is. We actually have what's called the Heart and Vascular Institute, or HVIS. We have a dedicated neurovascular suite. We do a stroke is in fact one of our least common procedure that we do. We have a very large neurovascular patient population, AVMs, aneurysms, that sort of stuff. So we do have a dedicated neurovascular suite. We call it the HVIS suite, so we don't do it in a hybrid room, and we do not share it with anyone.
Okay.
We use that nomenclature just so that it wouldn't confuse people.
It's sort of kind of universal. People kind of know what that is.
Okay, gotcha. Thank you for clarifying. Ellen chatted in, what do you do in the ED to decide who is your endovascular patient? Do you have a standard algorithm, CTA/CTP?
We do have a standardized algorithm. We try to take, again, one of the things that we've noticed is, again, to try and take out variability, is to protocolize things as much as possible, obviously while leaving, room for people to practice medicine, if you know what I mean. So I'm not giving people a recipe by which they cannot deviate. Right. But the idea being that if you can protocolize as best as possible, it limits variability and will have people move from one position to another. We have a standardized imaging protocol, and we use that with patients with suspected large vessel occlusions. The issue with CT perfusion is always a hot button and has been a hot button for decades. As to whether or not it's reproducible, et cetera. But at this point, we do not have a standard protocol for CT perfusion. There's been the DAWN trial we were involved in, which is a trial looking at extended time windows for stroke. CT perfusion was a part of that. But as a regular part of our algorithm, CT perfusion is not. CT angiogram is, with CT angiogram of the head and neck.
Okay, thank you. So what is your interventional radiology arrival to groin puncture time, and then do you have a process for this? Arrival
where? To the ED door?
I'm not sure. Christina asked, what is the IR arrival to groin puncture time? I'm sorry, I'm not clinical, so I'm not hopeful in this situation. No, she's for the IR suite.
To the interventional suite to incision is less than 20 minutes. So it's usually on average at this point probably about 10 minutes. We can't really, we would love to say, the most meaningful measure actually would be, door to recanalization time, meaning the time that the patient hits the door, the ER door, to the time that we actually pull the clot out of the patient's head. That's going to be the most clinically relevant time. The problem is as part of that, there's many, many factors that you have no control over. So when looking and system maps and trying to figure out where you can affect change, the HVIS door to incision time, you can protocolize that. You can give people roles and responsibilities and decrease that time. Once I make an incision, it all depends on the patient's anatomy in terms of how long it's going to take me to get that clot out. It depends on clot composition, a whole bunch of other things that are in some ways beyond my control.
Right.
So the short answer to your question is that our door to incision time is now less than 20 minutes. And we did, although anesthesia is present for every case, we do not intubate patients, we do not start A-lines, and we do not start Foleys unless there is a situation where the other night I had a patient who was actually vomiting on the table. Obviously we can't do an intervention for risk of aspiration with somebody actively vomiting. So that patient was intubated. So there's, but anesthesia is present for every stroke that we do.
Okay. Well, thank you. I think with that will be our last question. And there's been some other questions about access to materials and that sort of thing, but we will follow up with you two offline. And after this webinar is over and once the recording is posted, we will send out an email to everyone who is registered for the webinar with some clarification or some direction on where they can find additional resources. And just as a last announcement, we send out an evaluation for our webinars, so we greatly value everyone's feedback. We're always looking to improve. But I would really, really like to thank you both for presenting today. I think as you can tell with the tremendous amount of questions that people were really engaged and were really interested in your project. So thank you both for all that you do, and thank you for your time, and I hope everyone has a great rest of their day.
Can I just make one
Sure.
comment, one clarification? I did make a comment that Christiana Care was the only level 1 trauma center in the state of Delaware. We are, in fact, the only adult level 1 trauma center. One of our partner pediatrics hospital is a level 1 pediatrics hospital, so we are the only one adult. I just want to make that clear. Okay?
Got it. Thank
All
you.
right.
And thank you, everyone. Have a great day.
Bye-bye.
Ladies and gentlemen, that concludes the presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.